Hello guys, hello family, hello friends. This is Dr. T and welcome to Clinical Medicine with Dr. T. So guys, so for this video we're going to talk about something different. Like we have been covering anesthesia. So I want us to give anesthesia a break for today, and then let's talk about portal hypertension. Portal hypertension. Portal hypertension is one of those conditions that is both a medical condition and a surgical condition. When it starts as a medical condition, and then when complications come, which we are going to talk about, then it becomes a surgical condition. And the reason for that is because there's rupturing of the varices, and then you need the surgeons to come in there. So let's talk about portal hypertension. So to understand portal hypertension, we're gonna need to go back to the basics and just try to understand the anatomy. And if we understand the anatomy well, it's gonna be easy to understand portal hypertension, and it's gonna be easy to understand why it presents the manner in which it does. So we have a liver here, that's our right and our left lobe, and then we have a spleen here, and then we have our stomach here, okay, fine, and then we have our umbilicus here, and then we have our rectum here, right? Now let's visit the veins. So we've got a vein that drains the spleen. That vein is called the splenic vein. Splenic vein. And the splenic vein, as it approaches the liver, it is joined by another vein called the inferior mesenteric vein. While we are at it, so the inferior mesenteric vein gives off branches, or it doesn't give off branches. So there are 3 veins that drain into it, and it's the first one is the inferior rectal vein. The other one is the middle rectal vein. The other one is the superior rectal vein. So inferior will be somewhere here, middle will be here, and then superior will be somewhere here. So this splenic vein and inferior mesenteric, they drain into the portal vein. This is the portal vein, right? And the portal vein, as just before it gets inside the liver, it splits into two, the right and the left portal vein, right? The portal vein gives off branches. Oh, it's not branches actually. You know, when we say something gives off branches, it's normally an artery. So with a vein drains into. So there's a vein that at this point that drains into the portal vein, and that's the right gastric vein, and also the left gastric vein. The left gastric vein and the right gastric vein, they join and form a loop. And the left gastric vein is also called the coronary vein. You know, when someone talks about the coronary vein in the abdomen, you become so confused because you expect the coronary vein to be in the heart, but it's also called the coronary vein as well. That's the left gastric. We've got the left gastric and the right gastric, and these two veins, there's another vein that drains into them, and that vein is the esophageal. It drains the lower half of the esophagus. Esophageal vein. Guys, I'm not a person who likes anatomy or physiology. If I do anatomy or physiology or anything that is basic sciences, it's because there's a direct clinical correlation. So please bear with me. So, and then also from there, this one, there's a lot of variation. Some people will tell you that the umbilical vein is directly from the portal. Some will say it's from the right or the left portal vein, but then doesn't really matter. So you've got the umbilical vein there. Now remember, there's a very big vein that runs somewhere here, which is called the inferior vena cava, and it drains blood to the heart. So the right and the left portal veins, they sort of like take blood to the liver, but blood from the liver is drained through the right hepatic, the left hepatic vein, and the middle and the left hepatic vein. They drain into the inferior vena cava. Let me make it green. Inferior vena cava, like that. So guys, what happens now is that with portal hypertension, once we hear the word hypertension, it means there's an increased pressure. So what we know is that with portal hypertension, you've got an increased pressure. So there's an increased pressure in the portal system. And this increase in pressure has got different pathologies or different reasons. And this pressure needs to be more than 5 millimeters of mercury. It needs to be more than 5 for it to be high. Otherwise, it's between 1 and 5. Usually it must be more than, let's say more than 6. So as long as it's between 1 and 5, it's still normal, the pressure in that system, right? Now, what we are going to talk about the causes. We're going to talk about the causes of portal hypertension. But what I want us to discuss now is when you've got an increased pressure in the portal system, how will the patient sort of like present? So let's start it here. So let's say you've got some form of an obstruction, so blood cannot move freely from the lower half of the body back to the liver and back to the heart, right? So when that happens, you're gonna start having this portal vein is gonna start to dilate. It's gonna start to dilate, and because of the high pressure, you know what happens when you've got high pressure? Whatever that is fluid will run away from the high pressure and look for a part that has got least resistance. So when you've got blood when you've got pressure in the portal system, blood will start to go back because it's running away from the high pressure. It will start to go back like that. Blood is supposed to move from here like that, from here like that, from there like that. But now you're going to have a situation whereby blood starts to go back. And when blood starts to go back, you're going to have a dilated splenic vein. And the splenic vein will accommodate the blood, but it's going to get to a point where it can't accommodate the blood anymore. So you're going to end up having a lot of blood that goes back to the spleen and stays there. And when that happens, you're going to start having a splenomegaly. So you're going to start having a splenomegaly. And that spleen is just trying to accommodate the blood that is coming back to it. You get a splenomegaly. Because the pressure is in the entire portal system, so the blood will start to flow back into the inferior mesenteric. And when that happens, you get dilatation or dilation of these veins. And then now a patient starts to have hemorrhoids. So here is splenomegaly. These are the clinical features you're gonna pick up from a patient who has got portal hypertension. So the same thing is gonna happen to the umbilical vein. For this, and then you will get what they call a spider nevi. Spider nevi or spider nevi, whatever they call it. Spider. But basically, you're gonna have, I'm not sure if you guys have seen it, but a patient who's got portal hypertension, if you look around the umbilicus, you're gonna start seeing small veins that are dilated that look like a spider web, kind of. That's a spider nevi, and it's because you've got a dilatation of the umbilical vein because of the high pressures in the portal system. Now, when this congestion happens in the right and the left gastric, you're gonna get the esophageal veins also being dilated, and that will give you esophageal varices. Esophageal varices, right? What else am I leaving out? So all of these are clinical findings. I mean, we hardly take a patient to be to have the patient measured their portal pressures just because we suspect that they've got portal hypertension. We hardly do that. This is a clinical diagnosis, but in cases whereby there is uncertainty, then maybe a patient can go for a test. So in terms of, I think this is just for, in case someone asks, the portal pressure is between 1 and 5. Once it's more than 6, then it's high. Once it's above 10, the patient will start to have symptoms, will be symptomatic. Once it gets above 12, the varices are likely to bleed. They're high risk. There's a high risk of bleeding once the portal pressure gets to above 12. So just to repeat, normal pressures between 1 and 5. Once it's above 6, it's abnormal. Once it gets above 10, the patient will be symptomatic. Once the pressure gets above 12 and above, the varices are likely to bleed. Now we're going to talk about the causes in another video, but the way the causes are classified, you have got pre-hepatic, you've got intrahepatic causes, then you've got post-hepatic causes. The intrahepatic causes are further classified into pre-sinusoidal, sinusoidal, and post-sinusoidal. We're going to talk about those in another video. Thanks for watching. So guys, just before I leave, so we're going to talk about the clinical presentation though, but when you have a patient who's got abdominal distension, ascites, spider nevi, you have to examine that spleen. You have to examine the rectum as well, the anal PR, rectal examination, and confirm those hemorrhoids or ask the patient about hemorrhoids, and also ask about history of vomiting, blood, hematemesis, and stuff like that.